I will provide the hierarchy or the levels of evidence with regard to clinical prediction model development and use, and take you through the various steps in development and evaluation of clinical prediction models. There are overall 6 broad steps, and then within these 6 steps, further steps that one has to undertake to meet the methodological standards for the use of clinical prediction models. And I will describe the 2 main characteristics of a clinical prediction model, which is discrimination and calibration, and talk about one aspect which is very often omitted when we talk about clinical prediction models, and that's impact analysis. So let us begin with a scenario. You are a hepatologist who works at a large academic center, and you see a growing number of patients with non-alcoholic fatty liver disease who are at risk for HCC. One of your patients, a 52-year-old male with well-controlled type 2 diabetes, hypertension, and advanced fibrosis, presents for a routine follow-up. His most recent liver function tests are stable, and he has no symptoms suggestive of decompensation, and he has no history, prior history of HCC, but his ultrasound findings are reveal mild heterogeneity with no definite lesions. In your experience, patients with advanced fibrosis who are non-cirrhotic face significant risk for HCC, but in your experience, there is no validated model that predicts the risk for HCC development in the next 3 to 5 years. So you consider the need for a new clinical prediction model that could help assess the risk of HCC in fatty liver disease patients with advanced fibrosis even before cirrhosis is established. And using this model, you aim to stratify patients at high risk for HCC, allowing for earlier, more personalized interventions like intensive surveillance. So you'd be interested in both looking for a model that can stratify risk for HCC in such a patient, as well as, if not available, you'd want to develop one by designing a new study. So there are a number of ways through which one estimates the likelihood of an outcome. There is, of course, physician intuition, first of all, that aids in determining whether a patient is likely to have a particular outcome or not. But it's been documented that physician intuition very frequently overestimates the risk in patients. Another place that one can go to for probabilistic outcomes or probability of outcomes is observational studies. But you will see that, say, an observational study, which is, suppose, a prospective registry, it will give the average risk across all of the patients that are there. So it provides an average risk overall of all the patients, whereas you'd probably want to, you'd probably be interested in the effect of one particular determinant or risk factor, like age. How does age in particular influence the likelihood of the outcome? So observational studies are one place to go to, but they provide an average risk, and prognostic studies very often give a hazard ratio, which provides the individual contribution of one particular predictor to that likelihood. So that's why we need clinical prediction models. We need them because it provides us with the risk that each predictor contributes to the likelihood of an outcome and combines the risk across various patient characteristics. And using some statistical techniques, we can actually get an absolute risk of the outcome from the clinical prediction model. So these are basically decision aids that can be used at the point of care to make prognostic decisions or diagnostic decisions by physicians. And they usually combine components of history examination or simple laboratory tests to give a probabilistic outcome. So clinical prediction models, some people don't like to use the term rules. Clinical prediction models estimate probability of a clinical condition or future outcome by considering a small number of highly valid indicators. These could be patients' clinical findings, history, or investigation results. And it utilizes statistical techniques to identify a manageable number of variables that provide estimates of a patient's likelihood of the target outcome or diagnosis of interest. Now, in the scenario which we considered in the first slide, we were talking about a problem where our interest was prognosis. So we wanted to know what is the prognosis of these patients with regard to risk for HCC. But the output of a model could very well be a diagnostic outcome. So what is the increase or decrease in likelihood of a particular diagnosis? Or it could actually be a decision. So some authors make a distinction between assistive predictive rules and directive decision rules. So directive decision rules would actually guide a physician towards a particular treatment or further diagnostic test, whereas a prediction rule would just simply give the prognostic predicted probabilities without recommending specific clinical course of action. So in this context, regardless of whether the output of the rule is a prediction, a decision, or a diagnostic probability, we will use the term clinical prediction model to mean all of these different things. And certainly in this context, there are a whole array of terms and terminologies that have been used to refer to this same concept, this concept of clinical prediction models. The terms that have been used are clinical prediction tool or algorithm, clinical decision rule or tool, prognostic score, risk prediction model, risk score, scoring tool, scoring system, or risk index. And within this domain are scores like MELD, CTB, FIB4, and simplified diagnostic criteria for autoimmune hepatitis. So the simplified diagnostic criteria would constitute a diagnostic clinical prediction model, and the MELD would be something that would pertain to prognosis. So this slide gives the broad overview of the three main steps. So there is consensus largely amongst all authors and publications that development and evaluation of a clinical prediction model comprises of three main steps. The first, typically, when we derive a model, it is off of a single set of patients in a single data set. And once we've derived that clinical prediction model, we go out and validate it. And we'd want to further validate it in 2 or 3 different groups of patients. So the first step, derivation, pertains to identification of factors with predictive power. And basically, it is the examination of the ability of multiple variables from clinical findings, history, or simple laboratory tests to predict the target outcome of interest. So this is something that's done all the time. We do multivariable regression all the time in our studies, and this is aligned with that technique. So once we have this model with us, we have the predicted probabilities that are derived from statistical analysis of patients with known outcomes. We then want to go out and validate this model in different groups of patients. And here, there are 2 terms that you will come across when we talk about validation of a clinical prediction model. And those 2 terms are discrimination and calibration. I'll talk more about these 2 properties further down, but if you ever read or happen to come across an article that talks about key characteristics of a clinical prediction model, you will read that the most important property of a clinical prediction model is calibration. But unfortunately, it's very underreported. There's documentation from a systematic review that only about 30% of papers on clinical prediction models provide the assessment of calibration. So validation is typically done as firstly a narrow validation. So application of the rule or model in a similar clinical setting and population as the derivation stage. And then further, we go out and do broad validation. So application of the rule in multiple clinical settings with varying prevalences and outcomes of disease. And lastly, a third step, which is most often not done, is impact analysis. So This is basically the evidence that a rule changes physician behavior and improves patient outcomes and or reduces costs. So we want to evaluate the effect of applying this model in a clinical setting. So how does it change patient outcomes, and how does it, is it cost effective, and how does it reduce costs, etc. So aligned with these 3 steps, there's actually a hierarchy of evidence. When we talk about clinical prediction models, the lowest level, level 4, is a model that has been derived but not validated. So level 4 is just derivation without validation. A model which is derived and then validated in a number of different settings is level 2. And finally, a model that has undergone impact analysis. So the assessment of the effectiveness of that model in a clinical setting constitutes the highest level, which is level 1. So what does this mean in terms of implications? If you come across a model which is just at level 1, so just derived without validation, then it's not ready for clinical use. What they've done is just identification of predictors using a multivariable model, and it needs validation and further evaluation before it is used clinically in actual patient care. If you find a model that has undergone narrow validation, which means that it is validated prospectively in one setting only, possibly in the same setting as where it was derived, then it needs validation in varied settings. So you may use that clinical prediction model cautiously in patients similar to the derivation sample. And similarly, using the same line of thinking, if there's a model that has undergone broad validation, then it means that it has been validated in a wide spectrum of patients and clinicians. However, it still needs to undergo impact analysis, which means that you still want to know what is the effect of that model when it is applied in a clinical setting. And then some papers further stratify impact analysis into broad and narrow. And the higher you go up in the hierarchy, the more confident you can be about the utility, the clinical utility of the model. So some authors have, in addition to these 3 steps of derivation, validation, and impact, they have described 3 further steps. The first is identifying the need for a clinical prediction model, and once you've derived and validated and assessed the impact, determining the cost effectiveness and long-term dissemination and implementation of the clinical prediction model. So these are further 3 steps. And so overall 6 steps, and we'll talk briefly about each of those. So identifying the need, well, it could be that you felt so in your clinical practice, a qualitative research with clinicians, or a scoping or systematic review of available models will tell you that this is an area where a model is required. But what is a matter of further consideration is whether you need a new model, or if you want to consider updating, validating, or testing existing clinical prediction models. So MELD, for example, has undergone an evolution with the removal of etiology and addition of sodium and further characteristics, etc. So very often, what you're trying to obtain in terms of clinical utility can be achieved through updating an existing clinical prediction model. But say you decide that you do require a new model. So you start out with your derivation stage, design a study which is a prospective cohort study that's specifically meant for the development of this clinical prediction model. So very often we do utilize data from existing data sets from other studies. For example, randomized controlled trials have the advantage of having very good complete data, which can be utilized. But one has to be wary that the representativeness of the sample that is studied in that RCT is limited. So for example, RCTs typically have a narrower range, age range, because they exclude elderly and young, etc., and exclude a whole number of other patients like pregnant women, high-risk patients, etc. And therefore, the representativeness of that sample from an RCT is limited, which impacts the qualities and the properties of that clinical prediction model. So ideally, you would want to use data from a study which is specifically designed, a prospective cohort study which is specifically designed to develop and validate a given clinical prediction model. And of course, the lowest evidence would arise from a retrospective database, which also has the challenge of a lot of missing data. So conduct a prospective multi-center cohort study to ensure representativeness of the population. And in that data set, we do statistical analysis to derive the clinical prediction model. So we conduct multivariable regression analysis. For binary outcomes like mortality or hospital admission, etc., we do logistic regression. So whenever the outcome is binary, yes or no, then logistic regression. And for time to event data, like prognostic outcomes or mortality at a particular time point, we do Cox regression. Now, a problem with data all the time inevitably is missing data. And very often what is practiced is case-wise deletion. So we only select cases for which we have complete data, which actually may bias the results, because it's not necessary that after excluding the missing data, what you have in your sample is a random subsample of the overall. It's not. Usually, data is not missing at random. So missing not at random is the commonest domain when we talk about missing data. So that's why there may be systematic differences in the overall sample and the sample that you've obtained after excluding missing data. So what is recommended is that you carry out multiple imputation. So that's making, the software itself makes assumptions, multiple assumptions, and basically it generates multiple different plausible imputed data sets and then pools the results obtained from each one of them. So multiple imputation involves that we first create multiple imputed data sets, and then we add variability to that data set because of the multiple imputation that has happened. And then overall, we combine the variability and we combine the estimates from all of those different imputed models. So that is what has to be.
Manya, can you explain a little more about imputation? This means missing data or a loss to follow up. What is imputation?
Yes, so when we talk about missing data, there are three basic types of missing data. The first type of missing data is missing completely at random, which means that the missing data is not related to any observed or unobserved characteristic. So it's just missing at random. The second domain of missing data is missing at random, which is a misnomer. It should actually be called missing conditionally at random, which means that it is related to one observed characteristic. For example, in your data set, you see that blood pressure is missing, especially in those that are young. So it is dependent on an observed characteristic, like age. And the third domain of missing data is missing not at random, which means that that missing data is related to both the observed and unobserved characteristic. For example, in your data set, you see that those with high blood pressure are missing because they have headaches. So it's related to the characteristic which is missing itself. Now the problem is that if the data is missing just at random, then it's not much of a problem because it doesn't introduce a systematic bias. It's just missing at random. It will only create uncertainty in terms of imprecision, not a bias. But if data is missing conditionally at random, so it's conditional on a particular characteristic, or if it is not at random, the third example which I gave, then it's a problem, because then your data is biased, right? Now, there's no actual way to ascertain whether the data is missing conditionally at random or not at random. You can't know, you'll never know. But most likely, when data is missing, it's not completely at random. It's usually not at random. So, which is why you can't exclude, you can't do case-wise deletion of missing data, because what you obtain in your sample is a sample which is systematically different from the overall sample, which is why we do multiple imputation. It's a popular approach to the problem of missing data, because it quantifies the uncertainty which we have with regard to the missing data. So it basically has 3 steps. The first is that multiple imputed data sets are created based on distribution of the observed data. And then this stage accounts for the uncertainty in estimating the missing values by adding variability that is created by creating those multiple imputed sets. So you have all of these different imputed sets that you have, and then in the last stage you combine the results of those imputed data sets, and you combine it using a number of formulas, and the standard errors are also combined. So that is one approach that basically gives credence to the fact that there's some variability and uncertainty that can be accounted for because of missing data. So once you have that data with you, what you have to do is select the candidate predictors for inclusion in a multivariable model. Now, the recommended approach is that you include all variables that are of clinical relevance. So very often what is done is that we do screening using bivariate analysis, and then whatever is a p-value of less than 0.2 or 0.1, then we include it in multivariable model. But what makes more sense is that you use clinical experience and clinical judgment to include relevant predictors. And it's important that there's one rule of thumb which can be used with regard to clinical prediction models, that you can aim for a sample size of a minimum of 10 events per predictor, preferably more. So what this means is that if your mortality, say your outcome is mortality, and your number of predictors are say 5 or 7, then your sample size would be a minimum of 10 events, so 10 deaths per predictor, to obtain an overall sample size. So that is the rule of thumb. There are other formulae also that can help you to calculate the sample size, but this is one rule of thumb, minimum 10 predictors, and there is some literature that says even 20 is required, but at least a minimum of 10 events per predictor. And I already told you this, that we avoid selection based on univariable significance testing, and avoid categorizing continuous predictors. So very often we do an arbitrary cutoff to categorize a continuous predictor as high or low, and this should be avoided because it introduces arbitrariness into the data. And so we avoid data-driven selection, which just means that we use clinical judgment and clinical reasoning to identify predictors that could be important. And definition and assessment of predictor and outcome variables should be clear. So we should know what constitutes a predictor, what constitutes an outcome, and aim for blind assessment of predictor and outcome variables. Now, once we run the regression, what we get are regression coefficients. For example, in a logistic regression, you will get beta coefficient. And then regression coefficients are mutually adjusted for other predictors. So they represent the independent contribution of each predictor. And this coefficient is what helps you build the model. So this basically constitutes the clinical prediction rule, and it constitutes the weightage that is given to each predictor. I'll give you an example. This is one clinical prediction model which is derived for fibrosis in, I think, cholangitis. And so this is the model that they've derived from their, so these are all of the different predictors that were significant: hepatomegaly, platelets, albumin, cholesterol. And these coefficients and these weights are derived from the multivariable regression. So the probability of an outcome can be computed for a patient by combining the observed values of the predictors and their corresponding regression coefficients. And this number you see here, 2.42, this is the intercept. So there are two main components to the regression output, the intercept and the coefficient. And both of these together basically constitute the model, which is your clinical prediction model. And typically, the model provides outputs in terms of odds or log odds. And then to get the odds, you have to exponentiate it. So this is what this exponentiate term is. And then in order to get the risk from the odds, we take inverse. So 1 upon 1 plus odds is risk. So that is how you create this clinical prediction model. This is derived from the regression. The log odds are derived from the regression using beta coefficients and intercept. then you exponentiate it to get the odds, and then in order to get the risk, 1 upon 1 plus odds is the risk. Now, once you've derived your model, you have your model before you, now you have to set out and validate it. And you can do validation as a narrow validation or as a broad validation. When we talk about narrow validation, what it means is that we are usually validating it within the same setting where we derived it. So typically what is done is, it's not the recommended approach, but typically what is done is that we split our sample. So split it 50-50 or 60-40 or 70-30. And one set constitutes the training cohort or the test cohort, and the training cohort or derivation cohort, and the next set constitutes the testing cohort. So that's the cohort that you use to validate it, internally validate it. So performance overestimated usually when derivation data set is small and uses large number of candidate predictors. So this is often a problem, that we have too few patients in our data set and the predictors that we wish to study are too many. So this is called overfitting. And this is a problem because what this will result in is that the model will look very good in the training set. But when you set out to validate it, it will not perform that well, which is a phenomenon called optimism. So internal validation is done to examine and correct the amount of overfitting or optimism. And this can be done using split sampling that I just described, splitting the sample randomly 70-30, 60-40. But this is a problem because first of all, you have squandered your sample size that could have been used for the derivation. You've squandered it in the testing cohort, and also you could have utilized the entire sample. So which is why we do cross-validation and bootstrapping, which I will not describe in detail, but basically they are techniques that utilize the entire sample in order to get more precise estimates. If you require, I can talk more about this later if there's time. So now the most important part is that an ideal model will correctly identify every patient who will develop an event versus those who will not, and will not misclassify any patient. However, such a model does not exist. So the extent to which any model comes close to achieving this goal can be characterized by two related properties of discrimination and calibration. So those are two key characteristics of a clinical prediction model. What are they? The first, discrimination, is basically the ability of the clinical prediction model to distinguish high risk versus low risk. So that's saying that my risk is higher than your risk. However, calibration talks about the absolute risk. So it's not only saying that it's high versus low, but say the model says that my risk is 2% and yours is 1%. Are those really the correct values, or are they in fact 20% and 10%, where mine is still double of yours, but the absolute risk is actually 10 times, 10 folds. So discrimination talks about high versus low risk, and calibration talks about the absolute risk. Discrimination is about the ability of the prediction model to distinguish between patients with and without the outcome, and calibration is about agreement between predicted probabilities and observed outcomes. So it talks about the agreement between observed and predicted. Everybody is familiar with ROC curve and area under ROC curve. For logistic regression, area under ROC is same as C statistic, but calibration is not talked about and in fact very underreported. And the way that you can report it is using a calibration plot. And there's also a test called Hosmer-Lemichaud test. So in just 2 minutes, let me just summarize with what these properties are and then conclude. So discrimination, for example, it will tell you that the ROC is 0.85, which indicates good discrimination, meaning that the model correctly differentiates between those who will and won't experience the event. And calibration would tell you something like this. A well-calibrated model predicts 10% event probability, and in fact, 10% similar participants do experience the event. So it is observed and predicted. How much are they in agreement? So discrimination is necessary. The ability to differentiate high risk and low risk is necessary, but it's not sufficient. even if it is good, it may not be, the model may not be useful, because as I said, it could differentiate low, medium risk, but the risk may actually be 10, 20, 30 instead of 1, 2, 3%. And 0.5 ROC, area under ROC of 0.5 means no discrimination ability. So that's no better than chance. And 1 is perfect discrimination. And this is what it looks like, which I think most people would be familiar with. Sensitivity in 1 minus specificity are plotted. Calibration, not very frequently reported, is how close is the predicted risk compared to observed risk. And it refers to accuracy of absolute risk estimates, and the extent to which estimates are correct is given by calibration. This is what a calibration plot looks like. So this is the one that's observed, axis observed, and this is the expected from the risk score. So they had made a risk score, the meta-analysis global group in chronic heart failure had given a risk score for expected probability in patients listed for heart transplantation. And you can see here that above 30% of expected risk score, the model underestimates the probability. So the actual observed probabilities were way higher, which led patients to defer transplantation, which is why it was a problem. And then let me just conclude the further steps that you have to do external validation, which is again a prospective multi-center cohort. And then addition to this, there are additional stages of cost effectiveness, long-term implementation and dissemination, and maybe conduct a formal economic evaluation and sensitivity analysis. There was a survey that took into account what are the barriers to use. Physicians are there's lack of awareness that there is an existing clinical prediction rule. Some people think it's not useful, there's distrust. Very often it's too complicated or requires too many tests, and perceived risk of litigation leads physicians to anyway run the test, or data collection issues could be there. These are the key sources that one can go to where if you're developing a clinical prediction model or you're trying to interpret one. The progress framework, tripod for reporting, and probust is a risk of bias tool for clinical prediction models specifically. Everything that you need to know about clinical prediction models is summarized in these 3 papers. There was also a paper in JHEP recently, but these 3 papers summarize everything: the BMJ paper on developing clinical prediction models, the JAMA user's guide, and the paper on diagnostic and prognostic research, where most of this material is from. So let me summarize. There's a hierarchy of evidence when we talk about clinical prediction models, ranging from derivation to broad impact. We develop them using multivariable analysis. Validation is the next step. Once you derive the model, can be done as narrow and broad. What's desirable is that you do an impact analysis, and the 2 key performance measures are discrimination and calibration, where discrimination talks about high versus low risk, and calibration talks about the absolute risk. So what is the absolute risk with regard to observed and expected?